24 out of 26 patients who were already scheduled for spinal fusion or disc replacement avoided surgery. That was the outcome at 12 months in a study that injected bone marrow concentrate directly into their degenerated discs. Now, I want to be very clear. I am not saying regenerative spine therapy replaces surgery. Some people absolutely need surgery, but far too many are getting surgery without ever being offered an evidence-based alternative. Today, I want to fix that. I'm Dr. Trevor Turner, PM&R board-certified interventional spine physician at Pravida Health in Atlanta. My training covers the full spectrum of spine interventions, from epidural steroid injections and radiofrequency ablation to intradiscal biologics and surgical referral. That last part matters. I know when surgery is the right answer, which means I also know when it isn't. 400,000 spinal fusions per year in the US. But failed back surgery syndrome, persistent pain after technically successful surgery, affects up to 40% of patients in some series. We should be doing a better job before we get to that point. Let me explain why discs don't heal on their own. The intervertebral disc is the largest avascular structure in the human body. No direct blood supply. Nutrients diffuse in through the cartilaginous end plate. That diffusion capacity decreases with age, and it's inadequate when the disc is severely degenerated. When a disc degenerates, and this happens from biomechanical load, genetic predisposition, dietary factors, smoking, the nucleus pulposus loses water and proteoglycan content. Disc height decreases, annular tears develop, inflammatory cytokines, primarily IL-1 beta and TNF-alpha, are released and sensitize nearby nociceptors, turning the disc itself into a pain generator. Standard treatment, physical therapy, NSAIDs, epidural steroids, and eventually surgery. Epidural steroids reduce inflammation transiently. They don't address the degenerative cascade. And fusion surgery, for discogenic pain without instability, has a contested evidence base. A landmark 2016 JAMA meta-analysis found that fusion for degenerative disc disease showed outcomes comparable to or no better than intensive rehabilitation in patients without structural instability. The question regenerative spine medicine asks is, can we intervene biologically? Can we deliver growth factors and cells directly into that avascular disc environment and either slow the degeneration, reduce the pain, or stimulate repair? The evidence says, in the right patient, yes. Intradiscal PRP. PRP contains growth factors, PDGF, TGF-beta, IGF-1, VEGF, that support disc cell survival and matrix synthesis. The goal is to address the inflammatory and degenerative environment, not just mask pain. A December 2025 paper in the World Journal of Orthopedics, Patients Who Failed Conservative Management, showed intradiscal PRP significantly improved VAS and functional scores, with improvements approaching the level of physical therapy responders despite baseline differences in symptom severity. Multiple systematic reviews confirm a favorable safety profile. The primary risk is discitis, disc infection, which is rare with proper technique and antibiotic prophylaxis. Intradiscal BMAC, this is where the more compelling data is. Patin et al. Enrolled 26 patients, all of them candidates for fusion or disc replacement surgery. They injected autologous BMAC directly into the nucleus of the disc. At 12 months, 24 of 26 avoided surgery. VAS and ODI scores significantly reduced. At 24 months, 21 of 26 still hadn't had surgery. The 4 patients who eventually required surgery, they had MSC concentrations below 2,000 colony-forming units per ml. This reinforces what we see in the knee data. The cell dose matters. A systematic review of 16 studies, 607 participants, in the Journal of Pain Research found that intradiscal BMAC generally improved pain and function versus baseline, with some MRI evidence of improved disc hydration and height. The MRI piece is important. We're not just getting pain reports from patients. We're seeing disc T2 signal improvement, meaning increased water content in the disc, on objective imaging in a subset of patients. That's a biological signal. In my practice, regenerative spine interventions are for specific patients. Let me walk you through the selection criteria. Best candidates for intradiscal PRP or BMAC, age 25 to 65. For men, grade 2 to 3, disc degeneration, not end stage. No significant instability on flexion extension films. Discogenic pain confirmed either clinically or by diagnostic provocation, failed at least 3 months of conservative management, VAS pain greater than or equal to 4. Grade 4 or 5, severely collapsed disc, has less favorable biology for regenerative intervention. Grade 1 to 2, mild degeneration, the natural history may be good without intervention. The sweet spot is grade 2 to 3, where there's enough disc structure remaining to respond to biological therapy. When surgery is the answer, progressive neurological deficit, spinal cord compression, cauda equina syndrome, significant spondylolisthesis requiring stabilization. These are not regenerative medicine cases. I refer them to surgery, full stop. The distinction I make every day in my practice is this a pain problem or a structural problem? Regenerative medicine addresses pain problems at the biological source. It doesn't rebuild bone structure. If you're living with chronic back pain and you've been told that fusion surgery is your next or only option, I'd encourage you to find a physician who can evaluate you for regenerative alternatives before you commit to that. It's not the right option for everyone, but it's the right option for enough patients that it should be part of every serious conversation about spine care. The link to schedule a consultation at Pravida Health is in the description below. And if you found this valuable, subscribe. We do this every week. See you then.